Hello everyone, welcome to today's lesson with Caleb Mlonga. Today we're going to look at the nursing care plan for CVA, Cerebral Vascular Accident. So the condition we're going to look at is CVA, which stands for Cerebral Vascular Accident. It's also called stroke. Okay, so in our condition today, we will look at 5 to 6 problems that we are going to use in our nursing care plan, and we are going to write or discuss it in full. So we first start with problem identification for the first problem. So as we know in CVA, which is cerebral vascular accident, you find that it affects the respiratory system, meaning this particular person will be having difficulties to breathe. So when we're prioritizing our problems in the nursing care plan, one of the first things to consider is what we call the ABC. The measures, these are the 3 parameters that we use in resuscitation, and they mean airway, breathing, and circulation. So these are the 3 most cardinal. And if a condition has any of these problems, they should be among the first 2 or 3 problems. So because our patient is not breathing properly, because they have dyspnea, we are going to use that dyspnea as a nursing problem. So our nursing problem for dyspnea will be called impaired breathing pattern. Our nursing problem will be called impaired breathing pattern. Why is it called impaired breathing pattern? Because our patient is not breathing properly or is having difficulties in breathing. Then we move to the nursing diagnosis. So remember, the nursing diagnosis for the actual problem has 3 parts. The first thing is the problem itself, the second thing is related to, and the other part is evidenced by. So our nursing diagnosis will be impaired breathing pattern related to paralysis of the chest muscles and diaphragm, evidenced by dyspnea or labored breathing. So what we mean here is that this impaired breathing pattern is as a result of the paralysis of the chest walls, chest muscles, and diaphragm. And this can be seen or proven by this patient having difficulties to breathe. From there, now we move to objective or goal. So remember, the goal has to be smart. The goal has to be smart. So our goal is patient's breathing pattern will be improved within 30 minutes of hospitalization. Patient's breathing pattern will be improved within 30 minutes of hospitalization. So here what we mean is that this person cannot stay with labored breathing for more than 30 minutes. That means for problems such as labored breathing or ineffective breathing or ineffective airway clearance, we have to make sure that these problems are sorted out within 30 minutes of hospitalization, because if this person is not able to breathe within 30 minutes, they can develop other complications. From there, from the objective, we'll go and look at the interventions. So the interventions are, number 1, I will suction the airway if there are any secretions to clear the airway and prevent dyspnea. So that's the first thing that you do, to suction the airway if there are any secretions to clear the airway and prevent dyspnea. So that's the first point. Or before this one, you can add a point which can be, I will assess the airway to note if there are any secretions. Or you can say, I will assess the airway to check for patency. And then the second one can be, I will suction the airway if there are any secretions to clear the airway and prevent dyspnea. From there, we go to the third point. Our third point is, I will administer oxygen, supplementary oxygen, which is 4 to 6 liters per minute to increase oxygen perfusion and prevent dyspnea. So I will administer oxygen, supplementary oxygen, 4 to 6 liters per minute to increase oxygen perfusion and prevent dyspnea. Our other point is, I will monitor the patient for dyspnea so that I can note whether the condition is improving or deteriorating. So we have to monitor if the patient's condition is improving or not. How do we check that? We check that by noting or monitoring the dyspnea, whether it is improving or worsening. Then we go to the other point. Our other point is, I will monitor respirations to see whether they are within the range or not. So you have to check the respirations to note whether they are within the range or not. It is important so that we can know and note that the respiratory system is functioning well and there is no respiratory failure. From interventions, now we go to evaluation. The evaluation is, patient's breathing pattern is normal throughout hospitalization, evidenced by respirations within normal range. Patient's breathing pattern is normal throughout hospitalization, evidenced by respirations within normal range. So that's how we can evaluate. So the key is to make sure that this patient is breathing properly. So here where we have said throughout hospitalization, we can just say the patient's breathing pattern is normal after the 30 minutes of hospitalization. So even saying throughout hospitalization is okay, but don't forget to put the evidenced by. Then from there, we move to our second problem. Our second problem is impaired physical mobility. So where is this impaired physical mobility coming about? So as we know, in CVA or stroke, our patient will present with what we call paralysis. So this patient can be found that maybe they have paralysis of the limbs, maybe just the left leg, maybe the right leg. So they may have paralysis of one of their limbs or even all of their limbs. So you find that because they have some form of paralysis, that means they cannot use that particular limb. Okay, so they cannot use that particular limb. That means that they have impaired physical ability. They cannot walk properly. So for the fact that they are immobile, not maybe completely immobile, but they are not able to move as articulate or as freely as possible. Therefore, they're having difficulties. So in the nursing problem, we are going to say impaired physical mobility. Impaired physical mobility. So that's our problem. When we move to the nursing diagnosis, the nursing diagnosis is impaired physical mobility related to hemiplegia, evidenced by failure to move limbs on the affected part. So just like we said, this paralysis can be affecting both legs. It can be affecting both the legs and the hand, the arms, or it can just be affecting one leg, one arm, but it is what we call paralysis. So here related to which is the cause, it can be due to the cause of the paralysis of one leg or both legs and arms. So it is because of the paralysis that is why we are having impaired physical mobility. From there now we go to our goal. So mainly our goal is just to make sure that this patient is able to move, or the impaired physical mobility is reduced, which means that the patient will have improved mobility. So our goal is patient's mobility will improve throughout the hospital stay. So you can put it like, to improve the patient's mobility throughout hospitalization. That is the easiest way we are going to write our goal. And remember, the goals have to be SMART. Then from there, we move to our interventions. So number one, we're saying, I will conduct physical assessment to determine the extent of impairment. I will conduct physical assessment to determine the extent of impairment. So you have to do physical assessment so that you can see how impaired, or how worse, or how severe the impairment is, so that you can understand what interventions to put up. Number two, I will exercise the affected extremities passively to maintain joint mobility, regain motor control, and prevent development of contractures. I will exercise the affected limb or extremities passively to maintain joint mobility, regain motor control, and prevent development of contractures. So what we're doing here is that we want to perform passive exercises on the affected limbs, so that we'll make sure that this patient will not develop what we call contractures, or this person will maintain some form of joint mobility in the legs, in the joints of that limb. Then from there we go to the other point. The other point is, I will encourage the patient to exercise the unaffected side to prevent complications such as deep vein thrombosis. I will encourage the patient to exercise the unaffected side to prevent complications such as deep vein thrombosis. So it is very important that the patient exercises the other limb, or the other limbs that may not be affected, so that they may not develop complications. And our last intervention is, I will provide a wheelchair for the patient to use to help with mobility. I will provide a wheelchair for the patient to use to help with mobility. For example, when this patient wants to go to the toilet, or they just want to move about, it is important that we provide some form of assistance. And the first thing that we can do is just provide this wheelchair so that the patient can be using to move about. So those are the 4 interventions that we have under impaired physical mobility. And from there we go to the other one, which is evaluation. So under evaluation, we're saying physical mobility has improved throughout hospitalization, evidenced by ability to move limbs. So physical mobility has improved throughout hospitalization, evidenced by ability to move limbs. So just like that, straightforward. So our goal was to make sure that the physical mobility has improved, and our evaluation will be that physical mobility has improved throughout hospitalization. And what is the evidence? This patient is able to move their limbs. From there, we go to the other point, or the other problem. So you find that because this patient is unable to move their limbs, that means that they will not have, or they will not have the capacity to take care of themselves. When I said take care, I mean self-care, meaning they cannot be able to brush their teeth, they cannot be able to go to the bathroom, they cannot be able to bath themselves. So because of those things that the patient cannot do, it means their self-care will go down. And because of that inability of the patient to take care of themselves, we call it under the nursing problems as self-care deficit. Self-care deficit. So if I'm sure we are familiar with the ORM self-care theory, you find that this self-care deficit is one of the things that are highlighted, the problems that are highlighted under the ORM self-care theory. So when a patient is not able to perform those activities of daily living, it means that they have self-care deficit. So our problem will be self-care deficit. So we'll move to the problem, to the nursing diagnosis. Nursing diagnosis is self-care deficit in carrying out activities of daily living, self-care deficit in carrying out activities of daily living related to hemiplegia, evidenced by patient being unkempt. So self-care deficit in carrying out activities of daily living. So these activities of daily living can be hygiene, toilet, feeding, grooming, dressing up, and all those things. And why is it like that? Because this patient is having some form of paralysis. And how can you tell? Because the patient looks unkempt. When you say unkempt, you mean the patient does not look clean. Okay, so we go to the goal. So our goal is patient will carry out activities of daily living with the nurse's assistance throughout hospitalization. So we can say that one to say patient will carry out activities of daily living with the assistance, with the nurse's assistance throughout hospitalization. Or we can put it to say to improve self-care of the patient throughout hospitalization. To improve self-care of the patient throughout hospitalization. So having said the goal, we can move now to the interventions. So number one, I will encourage the patient to carry out personal hygiene activities as soon as the patient can sit up in order to improve hygiene. So the first point is I will encourage the patient to carry out personal hygiene activities as soon as the patient can sit up in order to improve hygiene. So you have to encourage them. Number 2, I will assist the patient to bath in order to remove dirt and prevent infections. Remember, this patient is polarized. Polarized. It may not be in both legs or all the limbs, but because of the paralysis, they may not be able to move themselves and go to the bathroom. So we are going to perform an assisted bath. Why are we doing it? It is because we want to remove dirt and prevent infections. Number 3, I will encourage the patient to carry out self-care activities such as combing hair, brushing teeth, and dressing to promote grooming. So here we are going to encourage our patient to carry out these activities of daily living, such as brushing, combing their hair, brushing their teeth, dressing up to promote grooming, to promote hygiene, and all those things. Number 4, I will encourage the patient to feed using an affected hand to improve the nutritional status. So depending on the intervention, depending on the scenario or the condition of the patient, if the patient is having one limb, one hand that is not paralyzed or affected, we have to encourage the patient to be using that the same hand that is not paralyzed to eat, so that they can have an improved nutritional status. Then we also have another one, which is I will assist the patient in meeting toileting needs using a bedpan. So I will assist the patient with a bedpan when they require or when they want to open bowels. So basically what this point is just saying that I will assist the patient to meeting toileting needs using a bedpan. So because this patient is immobile, that means that when they want to open bowels, we can offer them the bedpan. And this bedpan will be very useful because they will not have to strain to go out of bed. They are not even able to move. So those are the interventions. So all the interventions here are aimed at achieving the goal, and they are all addressing what we are calling self-care deficits. So all these points are trying to solve self-care deficit. Lastly, we look at the evaluation. So the evaluation is patient is carrying out activities of daily living with nurses assistance evidenced by patient being kept. So here the evaluation is straightforward, where we're saying the patient is carrying out activities of daily living with the nurse's assistance evidenced by patient being kept. So that's our evaluation for self-care deficit. So if we have any questions as we are going on, as we are going forward, let's make sure we comment in the comment section so that we can address them and answer. So from there now, we're going to look at another problem. Another problem that we have, we'll start with an actual problem, then end with a potential problem. So the fourth problem that we can put here is impaired swallowing. Impaired swallowing. So remember that this patient is paralyzed. And this paralysis can also affect the muscles on the neck, or the muscles that are used to swallow. So they can affect the larynx, the pharynx, the trachea, the muscles of the esophagus. They can affect any of the muscles that are found on the neck. So because of that, find that this patient will not be able to swallow properly. And because of that inability to swallow properly, we are going to call it as impaired swallowing. So impaired swallowing is our fourth problem. So we move to nursing diagnosis. So our nursing diagnosis is impaired swallowing related to paralysis of the muscles that help with swallowing. Impaired swallowing related to paralysis of the muscles that help with swallowing, evidenced by food dribbling out of the mouth or aspiration. So what we are saying here is that the patient will not be able to swallow properly. And because they are having difficulties in swallowing, we are going to call it impaired swallowing. And this is because of the paralysis of the muscles that helps in swallowing. How can you tell that this patient is having a problem in swallowing? This is why you see the patient dripping or dribbling the food out of the mouth whenever they are eating, or even aspiration of these foods. This patient can just start choking or aspirating the food content. From there, let's look at the goal or objective. Goal or objective. The goal is the patient will not experience food dribbling from the mouth or aspiration throughout hospitalization. The patient will not experience food dribbling from the mouth or aspiration throughout hospitalization. So basically what we want here is that we want to improve or to reduce, let's use the word improve, to improve swallowing. Want this patient to improve swallowing. So that's what we want to do. So this goal where we are saying patient will not experience food dribbling from the mouth or aspiration throughout hospitalization is a very good goal, and it is smart. From there, we're going to look at the interventions. So number one, the intervention is I will assess the patient for the extent of impairment so that I can put in appropriate measures for feeding the patients. So I will assess the extent of the impairment so that I can put in appropriate measures for feeding the patients. So the first thing in most of these points is that you have to assess the patient for the extent of the impairment. Then the second one is a nasogastric tube is used to feed the patient when the impairment is severe in order to meet the nutritional needs of the patient. So we are going to insert a nasogastric tube for feeding in severe instances or when the impairment is severe. Then number three, we are saying I will weigh the patient weekly to assess whether the patient is gaining weight or not. I will assess the patient weekly I will weigh the patient weekly to assess whether the patient is gaining or not. So the other points that we can also include here are, for example, I will refer this patient to a physiotherapist to help with the polarized muscles for specialized care. So I will refer these patients to a physiotherapist for specialized care. So we need these people who are specialists to assess and look at how they are going to help this our patient. So those are some of the points that we can include under impaired swallowing. We go to the evaluation. So the evaluation is patient has not experienced food dribbling from the mouth or aspiration throughout hospitalization. Patient has not experienced food dribbling from the mouth or aspiration throughout hospitalization. So it is very important that we evaluate this patient. And according to our evaluation, we can see that this patient has not experienced food dribbling. So your evaluation should be in line with your goal. And lastly, our problem will be risk for impaired skin integrity, which can also be put as risk for pressure sore formation. So I'm sure the most common one that we have or that we know of is risk for pressure sore formation. Risk for pressure sore formation. So we move to the nursing diagnosis. So nursing diagnosis, risk for pressure sore formation related to hemiplegia or decreased mobility. So remember, this patient is not able to move because they have some form of paralysis which can be in both feet, both legs and arms, or they can just be localized, meaning on one leg or one hand, like that. So because of that, you find that this patient is immobile. And if you remember quite well, in fundamentals, we learned of a topic called mobility. And one of the factors or one of the consequences of immobility is that you may develop what we call pressure sores. Why? Because there is too much pressure that is being exerted on the skin. So there will be too much pressure on the skin exerted. So the body is pressing the skin on the surface, and that pressure is prolonged and there is no relief. Therefore, there will be some form of sores that will start coming up. So these pressure sore formation are as a result of being bedridden, paralysis, or decreased mobility. So that's how we can write the nursing diagnosis to say risk for pressure sore formation related to hemiplegia or decreased mobility. The goal and objective or objective. So the patient will have intact skin throughout hospitalization. The patient will have intact skin throughout hospitalization. So that one is straightforward. We want our patient to have an intact skin. From there now we look at our nursing interventions. Number one, I will change the patient's position to hourly to prevent exerting pressure on the affected part, therefore preventing pressure sore formation. So I will change the patient's position to hourly to prevent exerting pressure on the affected part, therefore preventing pressure sore formation. So we have to do 2 hourly turns or changing the patient's position. From there, our next point will be I will change sewed linen to prevent moisture, therefore preventing skin breakdown. I will change sewed linen to prevent moisture, thereby preventing skin breakdown. So we have to make sure that the linen that this patient is using, whenever it becomes soiled or dirty, we have to change it. so that this patient will not develop pressure sore formation, because those beddings are moist and dirty, which means they can cause pressure sore formation. From there, we look at the other point. Our other point is I will remove bread crumbs to prevent irritation or breakdown of the skin. So here we can use the term breadcrumbs or any dirt. So what we want here is that the bed remains free. The bed remains free. So we do not want this patient to be sleeping on a bed that has some form of dirt, like breadcrumbs or some food particles on the bed, because all those things can cause irritation to the skin. So we do not want that to happen. Therefore, you as a nurse, you have to make sure that you conduct bed making and remove all the breadcrumbs or any dirt on the bed to prevent irritation. The number four, the fourth point is I will straighten the bottom linen to prevent skin irritation. I will straighten the bottom linen to prevent skin irritation. So when these beddings that we use are wrinkled, especially the bottom linen, when they are wrinkled or they have wrinkles, find that those um, wrinkles are going to irritate the skin. Therefore, in a patient who's bedridden or in the patient who's unconscious, you have to straighten the bed, the linen on the bed, so that that linen will not irritate the patient's skin. Then we can also include another point, which is I will conduct daily pressure area care to prevent pressure sore formation. So you have to make sure that you clean those pressure sores, pressure areas. We call it pressure area care, so that this patient does not develop pressure sores. So those are some of the interventions that we can put up. Of course, we have others that we can also put up. Then the last part is evaluation. So evaluation, patient has an intact skin throughout hospitalization, evidenced by absence of pressure sore formation. Patient has an intact skin evidenced throughout hospitalization, evidenced by absence of pressure sores. So the patient has intact skin, meaning there are no pressure sores. What is the evidence? Evidence is that we have not seen any form of pressure sore formation. Okay, so those are the 5 problems that we had, but of course we can also include other problems. For example, you can have imbalanced nutrition, less than body requirement, because this patient is not able to eat as much, have enough food as much. So the nutritional status is going to go down. Number 2, we can also talk of problems like anxiety or knowledge deficit. Those are problems that we can include in our nursing care plan for CVA. Also have other problems such as risk for infection, because this our patient has reduced immunity. This our patient has reduced immunity. They are prone to certain respiratory infections because they're immobile. Not only respiratory conditions, but other infections can also set in because they are immobile. So we have come to the end of our lesson. For those who have not understood and have questions, let's comment in the comment section. let's clearly state the question so that we can respond and answer to your question. So we have come to the end of our lesson. See you next time. God bless you.